I'm here to talk about an expansion of the DATA2 clinical phenotype, which is pure red cell aplasia. Actually, I know I'm not supposed to do acknowledgments, but I do want to highlight that the individuals that are named here on the slide, several of them are here, and they can add to some of the history and outcomes of these patients. Gadir Sasa is over here, and Hassan Hashem is somewhere here in the audience as well, who will be talking later this afternoon. And J.J. Strauss, I think, was supposed to be here, and I'm not sure if he made it, but I just wanted to point them out to you today. Okay, so I think we've come to recognize that DATA2, many of us first touch it from very different perspectives, and my perspective is as a hematologist. And the patients that I'm going to talk to you about today first start with two siblings. The first was born with very severe anemia. So I don't know how many hematologists we have in the audience, but a hemoglobin of 4.7 at birth is exceedingly low. He had a low reticulocyte count, so he had hypoproduction. And a bone marrow that was performed at 1 month of age showed that he had a normal cellular bone marrow with very few red cell precursors and some scattered lymphocytes. He continued to require red cell transfusions, actually until his ultimate definitive transplant. And within the first month of life, he was given a diagnosis of Diamond-Blackfan anemia. Now, I don't know how many people are familiar with that condition, but I just want to highlight a few things about DBA. So the differential diagnosis for pure red cell aplasia at birth is actually quite limited. And with continued red cell transfusion, it's even more limited without its resolution. And so DBA, as we refer to it in the field, typically presents before 1 year of age. Typically, the red cell size is large. They have a macrocytic anemia with reticulocytopenia, and without other significant cytopenias, although they can be observed in patient populations over time. These patients, one of the assays that we use to make a diagnosis of Diamond-Blackfan anemia is to measure the adenosine deaminase activity level in erythrocytes, okay? So this is likely measuring ADA1 activity, and it's elevated in about 80% of patients, and that work was nicely clarified by Bert Glader and Blanche Alter, who I think here is in the audience. There's Blanche. These patients will also often have elevated hemoglobin Fs. And if you look in the bone marrow, they will have normal cellular bone marrows, as did our initial patient, with very few red cell precursors. So this is the pure red cell aplasia phenotype. Many of these patients, when treated with corticosteroids, their anemia will respond. Some forever, some will be able to come off steroids without any recurrence of their anemia, and some of them will have relapses, but many of them will be steroid responsive. So getting back to our patient, well, let me just also add that DBA is a ribosomopathy. So this pure red cell aplasia in this context is quite different from ADA2 deficiency. But and about 60 or 70% of patients will have a mutation in one of the ribosome protein encoding genes, but about 40% will not have a mutation identified. So getting back to our patient, our initial patient, this child had a trial of steroids. His anemia did not improve. And then at the age of 4 years and 9 months, he underwent a bone marrow transplant. And this was with his 1-year-old HLA identical, phenotypically normal sibling. She was screened for anemia and macrocytosis and elevated EADA level, all of which were normal. And so they proceeded to transplant. And it was quite interesting because there was 100% donor chimerism. However, there was no evidence of red cell engraftment. So the investigators, or the physicians at the time, thought maybe they could investigate her a little bit further. They repeated several of the studies. They were normal. At this time, only one gene was found to be mutated in DBA, which was RPS19, and that was only available, sequencing was only available on a research study, but they participated and there was no RPS19 mutation. So the sibling, they thought, well, let's collect some peripheral stem cells, and they attempted to mobilize these with GCSF, and they were not able to get good a stem cell population from her. And so with that, after several more years, a match was identified in the registry. Well, there was a slight mismatch. And the initial patient, the oldest sibling, underwent an unrelated peripheral blood stem cell transplant and achieved trilineage engraftment. Now, many years later, he's doing fine. He's had no stroke, no skin manifestations that could be related to DATA2, and he has a normal immune phenotype. So he's done quite well. So this once phenotypically normal sibling donor presented at the age of 14 years. And at that time, she had a very severe anemia with a hemoglobin of 6.2. and a low reticulocyte count. Again, the thought was that she had DBA as well, but again, those markers that we look for example, elevated MCV, elevated hemoglobin F, or elevated EADA, those were all, once again, normal. She had a bone marrow evaluation, which showed, as you would expect from a patient with DBA, a normal cellular marrow with erythroid hypoplasia, well, actually aplasia in her case. And interestingly, there were these lymphoid aggregates, which is actually quite unusual for DBA, and some mild reticular fibrosis. So this is a picture of her marrow, and this is just showing here one of these lymphoid aggregates that was observed. Now, there were other features that were quite unusual, I thought, meeting her for the first time, was that she did have some features of immunodeficiency. There was evidence of EBV reactivation. She did have this history of recurrent aphthous ulcers, which she continues to do to this day. And there were several warts on her hands, less than 9, but like 6 or 7, that had been there for quite a long time, and a low IgM. And T and B and K subsets were not completely normal, with low percentages in absolute numbers of the CD19 positive cells and also these NK cells. The proportions of the brights and dims were normal, but there was some suggestion that maybe she had GATA2 mutation. And I think there's been some discussion of some patients with GATA2 presenting with more of a monomac phenotype. So sequencing was undertaken actually before I met the patient by the inpatient team, because again, they thought she must have DBA like her brother. And they looked for mutations in the ribosomal protein genes that had been previously reported to be mutated in some patients with DBA. And a chromosome microarray was looked at as well to see if maybe there were deletions in encompassing a ribosomal protein gene, all of which were normal. And so with that, we embarked on a trio analysis, sequencing both the parents and this 14-year-old girl. And with that, biallelic mutations in CECR1 were identified. One of them was a known pathogenic variant, and one at the time was just described as a variant of uncertain significance. On the structure here, and I apologize, I didn't put the citation here, but the structure, this is a glycine 332 nexus histidine pocket. But we didn't realize that there were other patients now that have a mutation at this position as well. Dr. Hirschfeld very graciously agreed to do ADA2 activity assays on our patient, and her level was exceedingly low. There was another sibling in the family who inherited both wild-type alleles of CECR1, and he had a completely normal ADA2 level. So with that, we made a diagnosis of DATA2 in this patient. Now, I have to say hats off to the group in the Netherlands, Dr. Van Montferrans, who had reported in a letter to the New England Journal 2 brothers that had this homozygous variant, and one of them first was diagnosed with atypical DBA. So this report is what kind of tipped off the clinical sequencing lab that this may actually be the gene, the mutations in this gene may be the result of our patient's phenotype. So they described this patient as having atypical DBA, and this particular child underwent a stem cell transplant from his HLA identical brother. And similar to our patient, there was non-engraftment. And what Joris reported to us, I think it was a trilineage non-engraftment, so slightly different, but definitely a tip-off that something was not right in that family. This donor went on to develop other features. Pure red cell aplasia was not part of his clinical features, however. So we reported our 2 patients last year at ASH, the American Society of Hematology meeting. And then shortly thereafter, we were contacted by 2 other groups. One, again, was Hassan Hashem, who's here today, who's at Rainbow Babies and Children's. And he reported a patient to us, and I'm including his data here, that presented at 3 years of age. And this child did have some other features, alopecia, some urticaria and hepatosplenomegaly, and some neutropenia. And another part of the phenotype that I don't have here was an immune-mediated anemia, immune-mediated thrombocytopenia, all of which resolved, but ultimately this child had a refractory pure red cell aplasia. Now, this child had a normal hemoglobin F, distinguishing, again, from patients typically that have DBA, a normal MCV, a low ADA2 level, and an immune phenotype like our child. This younger child never had his immune phenotype assayed. Didn't have any clinical features, however, of an immunodeficiency up until the time of his transplant. And then J.J. Strauss at Johns Hopkins reported to us a 2-month-old, a patient who was just diagnosed at 2 months of age with pure red cell aplasia, a DBA phenotype and diagnosis. This child had a normal MCV at diagnosis. They weren't able to get EDA or hemoglobin F levels prior to the first transfusion. Interestingly, this child has a very low ADA2 level. However, a mutation or pathogenic variants in CECR1 have not yet been identified. So I think this is a very important case, and I think it illustrates how important ADA2 activity assays are. And Dr. Hirschfeld, I can't wait to meet you, but right there, hi. I can't wait till it's online and in the way that we can just order it from our reference lab. This is super, super interesting and important. Anyway. So don't have any information on the immune phenotype of this particular patient as well. So there's 4 here where the pure red cell aplasia is the driving phenotype. Now, there are other patients that have been reported, and I'm just going to highlight these from the literature as well. So this is the patient that I described from the Netherlands and was homozygous for this variant, which has been reported in patients with DATA2 and other vascular phenotypes, et cetera. And then there were 2 patients recently reported out of Hebrew University, Dr. Ben-Ami and his colleagues, and our speaker earlier was from that group as well. And they reported 2 children presenting, again, very early, 1 and 2 months of age. They had a different mutations, homozygous mutations. They had low ADA2 levels, and they also had some evidence of immunodeficiency. So I think in summary, if we think about those individuals who present with pure red cell aplasia, is there anything that we can, any generalizations? I think that it's important to note that they can present, and it seems at least in this cohort where they've been identified as this being their primary manifestation, that they're presenting very, very early on in life during infancy, although our 14-year-old demonstrates that this phenotype can actually become apparent, at least present to clinicians in the teenage years. I think we can conclude that the MCV is going to be normal, and maybe the hemoglobin F and EADA, although we don't have a lot of data on these yet. Now, patients with Diamond-Blackfan anemia very frequently will have congenital anomalies, and these individuals do not, distinguishing it from DBA. But immunodeficiency, it may not be clinically apparent, but may be evident by laboratory testing, seems to go hand in hand with these patients. And there are varied CECR1 mutations, so there's not a strict genotype-phenotype correlation that would allow us to get some sense of whether these patients are at risk of other manifestations of DATA2, and specifically point to pure red cell aplasia as the primary phenotype. So, my area of clinical specialty is in bone marrow failure syndromes. So to me, the big question for us is, those 40 or 30 to 40% of patients who have a diagnosis of Diamond-Blackfan anemia, and particularly those with atypical DBA, are there patients there that actually have DATA2? And so as we get this out into the literature, I think many groups will now be looking at their genome data and hopefully, again, be able to get activity assays done on these patients. We have just a few patients in our patient population that don't have a mutation in one of the known DBA genes, so we have had activity assays done on these individuals, as well as exome sequencing that did not point out any CRCR1 mutations, but in terms of activity, the 2 patients that we've been able to screen so far did not. But I'm really hoping, individuals with the diagnosis of DBA without a known mutation will be screened for DATA2 as well. So what's the underlying mechanism? We don't know, but one hypothesis might be, these erythroblastic islands from which erythropoiesis evolves in the bone marrow, and there's this central macrophage, and so maybe this macrophage is affected by the DATA2. Just to wrap up, what's the treatment, the appropriate treatment for pure red cell aplasia? Now, these patients are transfused. They're dependent on red cell transfusions, of course, and that is accompanied by significant sequelae. I should note that, and I'd be curious if other people have had this experience or analyzed this, but our patient, the 14-year-old, when she presented with her severe anemia, it was really quite notable. At the time of her presentation, she already had evidence of iron overload. And I found this to be quite striking. Liver transaminases in the many hundreds, and after a short period of time had a liver biopsy that showed evidence of hemosiderosis and also some degree of fibrosis. So you know, we need to address this problem of the pure red cell aplasia. Corticosteroids are very likely not to be effective, and the 2 patients reported out of Israel apparently had a steroid trial. Our youngest, or the eldest of our sibling pair, he got a corticosteroid trial, did not respond. The patient in Ohio got a corticosteroid trial, did not respond, or did not have a response. So I think that corticosteroids as a treatment for these individuals is not beneficial. And again, if we look at patients with this diagnosis, carrying a diagnosis of DBA, some of these patients will get repeated steroid trials. So we need to stop that. Anti-TNF therapy. So with the urging of Amanda, she suggested that our 14-year-old should be put on anti-TNF therapy as prophylaxis for stroke. And it's also a question of whether or not this patient may have a response with respect to her anemia. The parents have been very reluctant. They wanted to go to transplant, and that's been delayed actually because of donor issues. So on Monday we're going to start. They finally agreed, and we'll see if it benefits her from the perspective of her anemia as well. Stem cell transplant, obviously, we have one patient whose anemia was cured, and we have another patient that Dr. Hashem will talk about whose anemia resolved, as well as the patient from the Netherlands. So this could be a treatment here. And so with that, I guess I'm not going to take any questions now, but I am happy to take them later. And thank you for your attention.